Hi, Mike Gibson, Carolyn Lam, coming to you on this episode of Heart Success, and we're talking about changes to the ESC guidelines that incorporate a lot of emerging data about heart failure with preserved ejection fraction. Carolyn, there were a lot of changes to the guidelines. Give us an overview, but then drill down a lot on the heart failure with preserved ejection fraction changes.
Yeah, well, Mike, first of all, I love that we're talking about heart success because boy, is it a year and time
Yeah.
to talk about heart success. And I wish I could say that the guidelines had changed a lot with heart failure with preserved ejection fraction. That is actually the one part of the heart failure guidelines that didn't change. And it was more the rest of it that really took strides forward.
Didn't change yet, but after this meeting, I think we can expect to see a lot of changes.
Exactly. So I was really privileged to be part of the task force this time. And what was very significant, obviously, was the introduction of new drugs for heart failure with reduced ejection fraction. Here you go. We thought we just recovered from the ARNIs, and here now we have totally new medications in dapagliflozin and empagliflozin, more or less the evidence-based SGLT2 inhibitors for HFrEF. And then another new medication that was introduced for the first time was vericiguat, the soluble guanylate cyclase stimulator that received the class 2, whereas dapagliflozin and empagliflozin received class 1 recommendations. But what I really love about the guidelines is that it tried to be very practical and offer a simplified approach. So gone was the layering upon layer that happened in all the past guidelines, which is the new drugs just get tucked under the ACE inhibitor and beta blocker and MRA and tucked and tucked and tucked. This time it got flattened out. And so we have the 4 class 1 recommendations for HFrEF, which are ACE or ARNI, beta blocker, MRA, and SGLT2 inhibitor. And they were just put in a row like that in a nice green box. So that's really nice because now it sort of frees everyone to say, let's just get everybody on effective disease modifying medications who should be on it. And it doesn't really dictate how you get there. Mm-hmm. So it allows some kind of, flexibility. And in fact, there was an entirely new figure on a phenotype approach, which I think is where the field is going, an individualized approach, depending on what are the comorbidities or indications any particular patient has for this medication versus another. I mean, it makes sense. So I really like that.
I got to tell you, I'm a little nervous about starting all those drugs at once. I feel a lot more comfortable doing it in the hospital. What's the Carolyn Lam approach to initiating these drugs?
So the Carolyn Lam approach is to keep it simple. And it's so much easier to see a patient with HFrEF and know my aim is to get all 4 on at the end. No, I'm not going to start all 4 in someone who's naive and whose blood pressure and heart rate may be unstable and so on. Of course not. So we're talking about someone who is decongested already, hemodynamically okay, and a pre-discharge patient would be someone like that.
Tell me,
that's a patient
dynamically okay. Does the wedge pressure have to be below 18 or what dynamically okay?
No, what I mean is not someone in cardiogenic shock or pre-shock or whose heart rate is like 50, we have to be logical here. So it's someone who has some blood pressure space, has heart rate space, has been decongested, because if not, you don't give beta blockers in an acutely decongested, unstable patient, for example.
Well, that's if people just do this without being thoughtful, that concerns me. So can't be congested, got to be stable. Okay.
Yeah. And in those cases, I would rather have little doses of more than one class than to sacrifice any blood pressure space or heart rate space with a very high dose of a single class. That's kind of the concept, you see. So if there's a very high blood pressure, this patient would be ideal to maybe start the ARNI and a beta blocker at the same time, perhaps. If the patient is diabetic and already on an SGLT2 inhibitor, I would continue it. You see what I mean by there's a logical sort of depending who the patient is in front of you. And that's what I like about the guidelines. It allows you to do that. And then after all of that is done in that basic 4, then comes the sort of, if you're African American, consider hydralazine and nitrates. If the heart rate, is still very high despite beta blockers and then sinus rhythm, consider ivabradine, and so on. If this is worsening heart failure despite guideline-directed medical therapies, consider vericiguat. The devices, flow the same way, so that's very nice. So that's for HFrEF.
So get 4 on it at a starting dose, and then start to titrate or tailor their therapy based upon what room you have to move on blood pressure and pulse.
Exactly. Okay, exactly. And renal function and potassium. So those are the main things that usually dictate how fast you can go and how high one can go.
And then on the F side, talk to us about, you guys are still trying to get all your names down. It was... now it's
oh gosh, talking to an interventionist. What did you just call it, by the way? Heart failure, Mr. ejection fraction.
Well, I'm not going to say heart failure, Mr. EF. Mr. EF. But so it's HFpEF, HFrEF, Mr. EF. But all right. So MEF. I'm going with HFmEF.
MEF. All right. So the MR, the Mr. used to stand for mid-range ejection fraction in the 2016.
Pushed that for a long time, and now it's good to see the community is really accepting that kind of term.
Yeah, so now though the name has, the M and R now stand for mildly reduced.
Okay.
And that's because of accumulating evidence that these patients respond to neurohormonal blockade, for example, similarly to those with more reduced ejection fraction. And so having that reduced in the name is supposed to trigger clinicians to give the patients the benefit of the doubt, with therapies that could help them. And I want to say, the ARNIs are a typical example, and your work with the FDA looking at data from Paradigm and Paragon was very influential in advancing the field that way. The approval for the FDA, by the way, very interestingly, was for adults with chronic heart failure, particularly those with a less than normal ejection fraction. So I have to tell you, behind the scenes, there was a lot of discussion on whether or not we should change the name of the higher ejection fraction heart failure into heart failure with normal ejection fraction. I'm surprised you're not rolling your eyes and sort of teasing us. What are you doing?
Well, but preserved seems to be a good compromise. But what is preserved and what's Mr. EF? How do you draw the line? Where do you draw the line?
All right. So Mr. EF is above 40, but less than 50. So 41 to 49. And preserved, we conservatively stuck to the old definition, which is 50% and above for the ejection fraction. But by the way, in all these different heart failure, remember, we're talking about heart failure. So the clinical syndrome has to be present. And I think sometimes we just lose the forest for the trees.
Heart failure is more than a number. There's a patient attached to that number, and you're treating the patient, not the number, right?
Well put. And so for HFpEF, the guidelines were published at the same time as emerging evidence. And I think we will talk about that soon, because at the ESC, we had for the first time a robustly positive outcomes trial in heart failure with ejection fraction above 40%. So that's super cool.
God, that was amazing. And any changes, though, other than the nomenclature in the management of HFpEF and the guidelines that we need to know about?
Yeah, so in devices, I think
the ARNIs, right?
Oh, yes.
Yeah.
Yes, the ARNIs got elevated. And then in devices, Something that was really talked about was how ICDs in non-ischemic HFrEF became a 2A from a class 1, and that's based on the Danish data. So interesting, something that was brought down in a recommendation. And I think too, something very important was an emphasis on pre-discharge optimization of therapy. And that's a very important one, because we should start seeing hospitalization for heart failure, not just as a time to tune up diuretics, but really as an indication that this patient is worsening. And that's the time to really optimize guideline-directed medical therapies and to push on disease-modifying medications. Add what you can, optimize it before the patient is discharged. And that was very nice to see that.
Yes. Well, Carolyn, thanks for that update. And thanks to all of you for joining us here live from the ESC 2021.